I will pass it to my co-chairman, Professor Wong, to continue to chair the meeting. Professor Wong?
Now let's move to the second presentation. Now our second speaker is Professor Tisomi Lim from Singapore. Our second speaker, Professor Lim, is the director, medical director of Tisomi Lim Clinical for Women and Cancer Surgery at Mountain Aromonia Hospital, Singapore. He is the president of the ONG Society of Singapore, the president of the Society of the Laparoscopy and Cervical Pathology of Singapore. He is also the chairperson of the Women's Gynecologic Cancer Awareness Committee of the Singapore Cancer Society, and the visiting specialist in the Department of Gynecologic KK Women's Hospital in Singapore. Today, Professor Tisomi Lim will be also sharing with us on is there still a role for minimally invasive surgery for cervical cancer, the Singapore experience. Professor Lim, please.
Thank you, Professor Huang, for your kind introduction. Firstly, I would like to thank the organizers for inviting me to share the Singapore experience. Yes, for the outline for my talk, essentially after introduction, I will talk a bit about the development of the radical hysterectomy in Singapore, followed by the what we call the midterm outcome of the surgical oncology outcome of the radical hysterectomy cases in Singapore. And then I'll talk a bit about the current evidence, consensus, and what we can do to improve outcomes. Of course, there'll be some overlap with what Professor Lee has spoken to earlier. Okay, so cervical cancer, we know, is the most common cancer in the world today, with 500,000 people diagnosed with it every year. But in Singapore, it's actually becoming less frequent, and it's now the 10th most common women's cancer in the last 10 years, with approximately about 210 to 220 women diagnosed every year now, compared to 20 years ago. Okay, so the thing is, right, I mean, Singapore, we are actually late adopter of the laparoscopic radical hysterectomy. Why? Is because I think the laparoscopic radical hysterectomy was actually only developed in the 1990s. And of course, at the time, a lot of case series showed that it's actually feasible to do it through laparoscopy. And there are a lot of non-randomized studies at the time showing that the outcome is good with low recurrence rate that's similar to a laparotomy. And of course, Professor Lee earlier alluded to the study from the center and showing the long-term outcome, which is very good, at about 8-year survival was more than 90%. Okay, so we only started doing laparoscopic radical hysterectomy in Singapore in 2009. The reason is because I ended my fellowship training. I spent about a year in France with Professor Gynaecological in 2008. So when I came back, then we started to perform laparoscopic radical hysterectomy. So for this prospective study, we accrued about 18 cases between the time frame of November 2009 to 2011. And because it was a new procedure, so we had to talk to the patients, telling them that it's new, never done in Singapore before. That's why the accrual was a bit slow. So we had 18 cases recruited in the first 1.5 years. Then we also performed our usual open radical hysterectomy. But nevertheless, right, when we compare the two groups, right, there's not much difference in terms of age, parity, BMI, in the stage as well. Of course, at the start, we were quite brave because we did go to stage 1B2, which is the largest tumor size we had for laparoscopy at the time was 5 or 6 centimeters. Okay, so our technique is essentially a standard 4-port technique as shown in this picture here. And we used manipulator in most of the cases, 90% of the time. Well, 10% of the time we didn't. And we use a harmonic ACE in combination with bipolar forceps in most of the cases. And we always perform the lymphadenectomy first before the radical hysterectomy, because if we find that the nodes is found to be positive, then of course we will abandon the radical hysterectomy. But the thing is, right, before, even though we use a manipulator in these cases, we usually remove it before we perform coarctomy, because we use the coarctomy tube. This is a linear coarctomy tube that we use, we insert it in, and then after that, then we do the coarctomy. And then the vaginal cuff is sutured either laparoscopically or transvaginally. The operator time for the laparoscopic radical hysterectomy is was somewhat longer compared to the abdominal radical hysterectomy, but there was definitely less blood loss. But there's no difference in terms of return of bladder function or adjuvant treatment in the small study. And there were no intraoperative complications. However, postoperatively, there was one fistula in the laparoscopic radical hysterectomy group and one body dysfunction. And even though the menopause was short, there was already one nodal recurrence in the laparoscopic radical group versus 3 in the open surgery group. But nevertheless, this small study showed that laparoscopic radical hysterectomy was feasible, and that's why from 2011 onwards, we put it in our guidelines that we can perform this kind of surgery for tumors less than 4 cm. Okay, then later on, we accrued more cases and we published another study. This was a prospective study from 2009 to December 2014. During which time, we have recruited about 51 patients who underwent a total laparoscopic radical hysterectomy and 85 open radical hysterectomy. We looked at the data sometime in 2016-2017, but published it last year in the GMIT journal. So in terms of patient characteristics, both groups actually were pretty similar. For the outcome, again, it took longer to do the laparoscopic radical hysterectomy compared to the open surgery. Blood loss, however, was less, and so was hospital stay. The patient stayed 1 day fewer compared to open surgery. However, there's no difference in terms of bladder recovery or the number of lymph nodes removed. In terms of the outcome, there's no difference between the two groups in terms of LPSI, lymph node metastasis, parametric involvement, and even the vaginal margin involvement. For adjuvant treatment, there's also no difference. If half of the group of patients who underwent laparoscopic radical hysterectomy didn't receive any adjuvant treatment. However, for recurrence, if we look at the data trees, we're actually quite surprised that there were actually twice the number of recurrences compared to open. 70% of patients who underwent laparoscopic radical hysterectomy had vault recurrence, peritoneal relapse, nodal, liver, lung, and bone metastasis as well, compared to the abdominal radical hysterectomy, about 8%. Of course, again, it can be the vault, peritoneal, and one patient actually had mets to the kidneys, and the lung, and the bone. And then we look at the overall 3-year survival and found that not so good. Our laparoscopic group had 86% 3-year survival compared to the abdominal hysterectomy group. After that, we decided to look at the size and found that if we did the laparoscopic radical hysterectomy for tumors less than 2 cm, actually the survival was the same, in fact very good, almost 100% for both open and laparoscopic radical. Whereas when we look at tumors above 2 cm, 2 to 6 cm, then the survival dropped drastically to 61.9%. Probably, I suspect it's because for laparoscopic radical hysterectomy, the learning curve is about 40-50 cases, and probably and I think the outcome was actually affected. Because later on, we decided to look at all the cases that we did until end of 2018, 2019. And we found that actually the outcome, the 5-survival outcome, wasn't too bad for the 1B1. Again, this is the old staging. We only adopted the new staging last year. So less than 4 cm. We found that actually the outcome for laparoscopy and laparotomy actually was still pretty good. During which time we analyzing almost 100 laparoscopic radical hysterectomy versus almost 200 open. and it's actually not too bad. But of course, bearing the fact that when we look at in our previous study, when we found that the 2 cm is better patients, so we actually have been doing patients with a smaller tumors in the last few years actually in KK Hospital. Maybe that's the reason why after that when we look at the data, the survival appears to be better now when we look at the entire group. Okay, so now of course, probably earlier, I mean the electro actually changed how the practice of radical hysterectomy in the last 2 years, and this, of course, there's a lot of critique of this trial, but nevertheless, is practice changing, and they show that the disease-free survival as well as overall survival is inferior compared to open surgery. And recently, the group also they just published in JAMA Oncology last month, doing a systematic review of meta-analysis. They found 49 studies, but in the end, only 15 were included in the meta-analysis because they are very strict selection criteria, as mentioned here. But nevertheless, even though there are 15 studies in the meta-analysis, there were 9,409 cases, and half of which was open radical, and the other half was MIS. And the meta-analysis showed that the pooled hazard of recurrence or death was 71% higher among patients who underwent minimally invasive radical hysterectomy. Likewise, the hazard of death was also 56% higher in the MIS group as well. Okay. Most of these studies were published in the last decade. In fact, I think 2/3 of studies was published after the LEC trial. So because of that, I think the entire consensus is that the many statements, like Prof showed earlier, the APAGE statement. This one is the South Korean statement saying that all cervical cancer patients undergoing RH must be informed of the electoral results. And then, but they stated that this surgery must be performed by skilled surgeons. And secondly, it must minimize tumor disruption or intrapreneur spillage, where possible during corpectomy. At least they give advice to the practitioner. Otherwise, for ESGO, as what probably showed earlier, open approach is the gold standard now. They just revised it. But however, they also mentioned that all MIS surgical procedures for cervical cancer, again, must be performed in highly specialized centers by properly trained surgeons. And every effort must be made to avoid spillage of tumor cells intraperitoneally. The Americans are a bit more vague, but however, NCCN still also stated that open radical hysterectomy is a historical and standard approach to treatment of early stage cervical cancer. And the SGO, they didn't give much advice. They just tell their practicing oncologists that they have to let their patients be aware of the studies, the evidence, and then discuss with them regarding the approach, surgical approach. So why is the outcome worse? So some suggested reasons is the use of the uterine manipulator, and of course the intracorporal corpectomy and the effect of carbon dioxide on the spread of tumor intra-abdominally. Using this cartoon that was shown by Professor Kuan from Germany, this was published in International Journal. It's quite nice, showing that they use this uterine manipulator. If let's say the patient has a big tumor, this cup cannot sit in properly, and when you manipulate the uterus, it can actually, the bits of tumor can drop off, and then when you cut around when you do a corpectomy, tumor can spill into the peritoneal cavity as shown in the diagram E. So what can we do to improve the outcomes? I believe that case selection, right, both our size matter. So I think Prof Nam showed in 2004 in Gynecology that when you first start off with tumors less than 2 cm, the survival is pretty good, 97.1% compared to the open radical hysterectomy, which is 98.9%, which is similar to what the Singapore study showed recently. And then there are also other studies in the last year, like this in this paper published in earlier this year in this Annals of Surgical Oncology, says that the tumor size of 2 cm appear to be independent discrimination criteria in patients whose prognosis is affected by surgical approaches. The relapse risk for laparoscopy has a hazard ratio of 2.1 if the tumor size is more than 2 cm. But if it's less than 2 cm, then there's no issue. And then another study from China, in a one-to-one matching, which was an analysis of 1,601 laparoscopy versus 1,601 open radical. They also found that patients with tumor size less than 2 cm had comparable 5-year survival, 5-year disease-free and overall survival, but not for more than 2 cm. And another study from South Korea also showed that MIS radical hysterectomy was not a prognostic factor in patients with tumors less than 2 cm. Exactly, what can we do to reduce the risk of intrapreneur spread? Of course, some people say don't use intramanipulator, and then close the vagina either the start of surgery or prior to colpotomy. In Japan, they showed that TRH with vaginal closure did not increase propensity for tumor spillage. And then another recent study showed that the no-look, no-touch technique may be useful in reducing recurrence risk by preventing intrapreneur spillage. This is where they create a vaginal cuff, avoid the manipulator, and minimal handling of cervix. So the cuff is, in this study, was created right at the start. They found that the disease-free survival, overall survival was similar between the laparoscopy group and the open radical group. Professor Kohler also showed that the transvaginal closure of vaginal cuff provides an excellent oncology outcome. So in the center in Germany, they've been doing this for more than a decade, and they showed that the 3-year, 4.5-year 10 survival was excellent. Right, the 3 years was 90%, 4.5 years 97%, and the 10 years overall survival was 95% in the group of patients who underwent this vaginal-assisted laparoscopic radical hysterectomy. So for the German group, they actually have a very nice publication published in International Journal. They also have a video of how they did this, which just came out in International Journal this year. So of course they had the laparoscopy where everything is done way down to the parameter. Then after that they went out to the vagina to create the vaginal, much like the vaginal radical hysterectomy. Then they once they do that, they'll return back to above to complete the transaction of the parameter and remove the entire specimen. In motion, this is just published 2 weeks ago, the Cervical study. This one's a pretty good study because this is a European multi-center, 89 centers, spread over 23 European countries. So it's retrospective observation, but nevertheless, right, the one thing I like about this study is they actually look at the impact of the use of neutron manipulator and the protective closure of the colpotomy over the tumor in mini-invasive surgery group. And they found that in our group as well, the risk of recurrence and the risk of death is 2 times higher compared to open surgery group. But they found that if you use a neutron manipulator, the risk is higher, 2.76 times higher hazard of relapse. However, those who do not use a neutron manipulator had a similar disease-free survival in the open group, and those who did the protective vaginal closure had similar rates of relapse compared to those who underwent open surgery. So they concluded that actually avoiding the neutron manipulator and using maneuvers to avoid tumor spread at colpotomy was associated with outcomes similar to open surgery. So they suggest further prospective studies, which fortunately, like mentioned Professor Lee earlier, the METO study will help to address this, and also found that there's supposed to be a large phase 3 multi-center trial in China as well, looking at this as well. So currently in Singapore, so patients, have to be informed of the current clinical evidence, both international and fortunately we also have local data, while making a decision regarding the route of surgery. And I still believe that laparoscopic radical hysterectomy can be offered if patient has a small tumor, no evidence of lymph node metastasis clinically or radiologically, and of course we can perform for usual histological types like squamous cell carcinoma, adenocarcinoma, or adenosquamous. And 2 years ago, we had the fortune to learn from Prof. Sandu. He came down to Singapore to demonstrate a case of laparoscopic radical extraction where he did a vagina cuff closure. So we also learned how to do it. So we did a few cases. So if the tumor is visible, then we just close the vagina cuff transvaginally and then proceed to do the laparoscopic radical extraction. However, the thing is, right, the patient has a cone biopsy, right? Cone biopsy done, but there's no visible tumor. I think we can still use a ultrasound manipulator safely. In fact, in the series of cases that we did have a few patients who has had a cone, and so far the patients are fine, and then there are no recurrences, even though a manipulator was used. So, in conclusion, I still have to state that open radical extraction is the current gold standard, as stated by many international consensus guidelines. However, I still believe that MI's approach should not be abandoned. And firstly, we need careful patient selection. Definitely need to have a skilled surgeon. Learning curve is 40 cases. And of course, we need to change our surgical technique in order to have better outcomes. And of course, definitely we want to wait results from the new trials which will incorporate better techniques. If there's time, I'll just show a quick video of the technique that we're using previously. So this is the video of laparoscopic radical extraction that we do in Singapore. Just skip. The cases that we do, 90% of cases were done using the harmonic ACE. This is how we're entering the rectovaginal space. So mobilizing the rectum off. So just getting the posterior parameter off the true sacral ligament. After which then is uterine left uterine artery. In this case, I'm doing the case from posterior compartment laterally and then to the front compartment. So I mobilize the bladder later. After taking the uterine, then move forward. So in this case, at this point in time, I'm still using uterine material from below to push up so that I can get it's easier for me to get the bladder down. Okay, I'm trying to get the lateral parameter off. Sorry, mobilizing the ureter off using the harmonics. Because using the harmonics, the problem is we have to be very mindful, because there's a hot blade and a cold blade. So sometimes we'll try our best not to touch the vital structure with the hot blade. I think this area trying to get a bit of the lateral parameter off. So having a good assistant is important. We need assistants who knows the key steps of hysterectomy. So in the corporate, before this step, I will have already removed the uterine manipulator, and then after that, would then insert a corporate tube. Okay, the problem is, at this point in time, this case I did it without cuff closure, of course. So if there's a big tumor, at this point in time, there's a danger where the tumor may spill into the intrapreneur cavity. Usually we will flush the vagina. Flush the vagina with saline to clear. Of course, I also use a V-lock to close the vagina wall. Okay. So that concludes my presentation. Thank you.
Yeah, thank you. And Professor Lim. Thanks for your wonderful lectures. And Professor Wong, can you ask some of the questions you want to ask to Professor Lim?
I think that you are very experienced in the surgery, but I don't know why there are so many patients with cervical cancer do MIS surgery in Singapore. Or because Singapore is a small country, so the majority of the patient comes from the international or comes from the Singapore local. And another question is any certificate need for MIS radical surgery in Singapore? Yeah, please.
Thank you for the question.
Yeah.
Okay, so firstly, because I just came out to private practice. Previously, I was the head of the department in the KK hospital for the cancer department, and in the entire whole of Singapore, we see 200 over cases of cervical cancer a year in the whole country, and in my hospital alone, we see about half of them actually. So 100 over cases actually are managed in KK hospital, which is the reason why we have a chance to perform a lot of surgery. So we do about between 40 to 50 radical hysterectomies a year in KK hospital. I think that's the reason why we're able to build up the case, even though we are a small country, because I think a lot of cases are actually being seen in KK hospital. That's the reason. Okay, with regards to certification, the reason. So I was the only person that was sent to learn how to do this 10 years ago in 2007, 2008. So so when I came back, that's when I started learning how to do this. And after which, after the learning curve, about 40 cases, that's when I started to teach others how to do this kind of surgery.
Okay, Professor Lin, another question from the audience is that how do you perform the vaginal cup closure before the colpotomy? Can you explain that?
As in closure of the vaginal cuff. Okay. This from the paper, because the technique that I learned, that I tried to do in the recent year 2018 was a technique shown by Professor Ando. That means we actually close the vaginal cuff before the start of the laparoscopy surgery at the beginning. So we will infiltrate the vagina. Right, after that, slowly set off the upper third of the vagina, and then suture both the anterior and posterior lips together to cover the tumor, the cervical tumor, before we proceeded on to do the laparoscopic radical hysterectomy without the manipulator. That means the uterus is manipulated by the assisting surgeon actually.
So most likely, after you complete the laparoscopic part of the radical hysterectomy, you go down to the vagina to close the vaginal cup before you do colpotomy, or I don't know the step, because once you're done the vaginal cup closure, you can't use the elevator, you can't help the laparoscopic part. So
actually, once you close the vaginal cuff, that means the assisting surgeon will just pull the uterus. I mean, he's the one that's manipulating the uterus now. Then I'll just have to carry on to do the radical hysterectomy, but without anybody pushing on the wall.
The paper about talking about that.
Oh, the paper. Okay, yeah, because the papers, they describe different techniques. Like the one of the paper describing, they do it before starting the radical hysterectomy, and then the German paper, they do it actually at the end. So that's why there's this video, what vagina assisted laparoscopic radical hysterectomy, which also actually is good also, because sometimes for the cases which I tried to do at the start, patient did bleed when we're doing the laparoscopic radical part, because I couldn't secure all the bleeders transvaginally. So as I thought about it, maybe next time I'll try to do it at the end, the colpotomy, what we call cuff closure and the colpotomy at the end. So that might perhaps reduce the bleeding.
Okay. Thank you, Professor Lim, for your sharing today.